Morning, everybody, and thanks so much to Anirudh for having inviting me to his course. It's a pleasure to meet all of you and also speak in front of the AOS audience. So I'm going to talk on when to and when not to operate in myopic traction maculopathy. Now, there's a myopic pandemic. You see, of course, that's a little different from what I'm talking, but you see young children now, day in day out. We know online, and they have varying degrees of myopia. Now it's not only hereditary, but I think there's a feature of environmental factors, the occupational factors, the COVID and all that. That disrupted the school patterns. The parents are so unhappy. So you see children who are glued to their phones and their screens, so they don't go out. So they have to do outdoor activities. It said there is a scleral shortening, and they also have to, so many of them are on atropine, low dose atropine in less than 10 years. So that's quite a bit of a problem which we are facing in India. So otherwise also I see a lot of myopes in Delhi where I'm placed. So I'm sure it's all over the country, but in Delhi where I've been all through, I've seen a lot of myopics who are high myopes more than 26 millimeters or 6 diopters of myopia. That's what's high myopia. So high myopia is associated with pathological changes. We wrote a review article, full article in IGO in 2018, and this is the article, and it's because I was a little fond of this entity, and I got to see a lot of these cases having posterior segment pathologies, especially myopic traction maculopathies and subsequent even macular holes, myopic macular hole detachment, which we reported before. And it's that these detachments are primarily because of the macular hole. So you don't have to just look at the periphery in these detachments. Of course, you'll do a nice screening with the indirect, but sometimes the hole in the macula, which is a responsible factor. So you look at the configuration of the, Linkov didn't probably describe this. So you got to look at the configuration. If it's shallower towards the sides, probably not reaching the sides. Just 2 days back, I booked a case for Tuesday. When I go back, I have to operate. It's primarily a detachment which is involving the inferior quadrant. It's not in the superior quadrant because of gravity. The macular hole tends to collect the fluid in the posterior pole and gravitate downwards. So it's an inferior detachment, shallower towards the periphery, and it may reach the aura. It's not necessary. It's like everybody says that classical teaching is RRDs, it's got to be the aura. But here, sometimes I've seen myopic, because I've seen a whole lot of them. My personal experience, I'm not talking from the book. And I think that's what Anil would like to hear from me. That I saw the detachment. I saw a similar detachment 2 weeks back, which I operated. The girl was a high myope. She was 31, 32 millimeter axial length. The problems about surgery are intraoperative problems are anyways there because we don't use long instruments. I've tried using long instruments, but they're not helpful. So you got to do certain maneuvers like depress the sclera, make the openings at 4 millimeters, do phakic patients as far as possible. Of course, put scleral buckles if you can. Otherwise, I do base shaving with the phakic eyes also. You can do quite well because these eyes are huge, elongated, so you can reach the aura very easily. It's unlike the other RDs, phakic RDs, where you can't reach the aura. And around this age is around 20s, 30s, beyond 15. That's when they develop this myopic RD. There's a thinning in the macula related to the myopia probably, and that's leading to the myopic RD. So the inferior quadrant, shallow RDs, superior quadrant is kind of escapes that. And look carefully at the macula. With the indirect only, you will pick up the hole. You'll see the choroid shining through. You see a loss of contrast, but the contrast, you can see the vessels through the central opening. This is what I just picked up. I booked for Tuesday. And so here the surgery is totally different. You don't have to buckle actually in the periphery because it's not going to help you. It was primary, you say scleral buckling only probably, otherwise. You drain and scleral buckle, you're going to fail. The main etiology is in the macula. So you got to be very careful that you do the peel the ILM after putting a little bit of perfluorocarmine liquid. I know there's Teflon, but if there's no traction, they usually have no traction. It's a very kind of a fresh looking RD. The one which I'm going to operate is about 3 months old because the detachment was not noticed. So they don't develop PVR so much. Probably it's the macula only involved, and there's hardly any RP there. Because myopes, they don't develop, the RP is all degenerated. So unlike other chronic RDs where you'll develop some PVR changes, in myopic RDs I feel there are no PVR changes. So much different, it's a different entity altogether. Inferior RD is different, but these myopic RDs are different. So uh, I'm just talking about this entity, which is very common there. It's not so uncommon. I wouldn't say very common, but very not so uncommon. It's multiple factors, which factorial. It's got vitreous creases. The vitreous is very tightly adherent to these eyes, and somehow pathological vitreous is there. And of course, vitreous is liquefied also, but it's the vitreoretinal interface. You find the vitreous adherent, so you might get a creases. So you have to lift up that part of the vitreous which is adherent to the inner retina. And foveus creases, the taut hyaloid, it's all common. And the eye lamp is supposed to be very, very rigid, and they have arterioles which are rigid. So all of which play a factor in pulling up the retina internally, and you got a posterior staphyloма also, so they might have an element. So this here you see this picture. I've seen at least three or four since I've left my parent institute, which I've worked for over 35, 40 years, and started my work here across, close by at the Southern Enclave Center, and it's primarily a retina center. So because there's no point doing things like refractive and all, very not interested. So I'm totally not interested in all those things. I'm just interested in seeing good imaging and seeing good pictures, and I take pictures of every patient which I feel interested and kind of, sorry, I'll go on fast. Okay. So this is what something we reported, long back. So we started seeing all of these cases. As soon as this OCT-A came into more importance. So even the Heidelberg gives you very good myopic scans of the OCT, and you can pick up. So Topcon is the other one which I have, the Triton. The Triton and Heidelberg combined, which I have because I got these because of the research, the intuitional. I had the academic interest. So this is a case very interesting. I saw 2 weeks back. Vision was very good, and she was maintaining very good. This lady, and usually often they are ladies, and the predominance of females in MTM. You see the cases and a very atrophic kind of looking internal retina. You might like to operate, but you see the vision. It's 6/9, 6/12, and that's what she was maintaining for the last year or year and a half. So I wouldn't touch this eye. This answers part of what Anirudh asked me, that when would you not like to operate. When I see this case, at each follow-up, I compare the OCT, the morphology, I check the vision, and I see the retina, the outer layers of the retina, inner layers of the retina, and I carefully study it. It's not just see the picture and that's it. So imaging is not ends at just seeing the picture in gross. So you'll look carefully, and then you'll see something. There's a little elevation over there. She said, I've got metamorphosis in the left eye. I said, no, your right eye is more affected. You must be the right eye. I kept pestering her, and she got a little upset. I said, no, the right eye is worse. Then I had a look again, and I said, oh, I have missed something. I ran back to the imaging room, which is next door. I told my optom, yeah, please get the octa also done. The octa done, and lo and behold, I saw the Nonneuovascular network. I said, oh, that's the reason. So straight away, the plan which changed, don't operate, but inject. So with clear cut, I've seen 2 cases since those 2 weeks. Similar. So the myopic CMDM can coexist, and also MTMs. This one answer to this query to this, and second is don't operate such cases which are stable with reasonably good vision, because the visual acuity after surgery may be grossly worse than this. So this is one thing which I'd like to pass across as a message. So of course, the traction from detachment, you should operate. So there's a rigid arteriole. So also scan. You should go to the imaging machine yourself. Don't depend on the optom. They are very good, but still, as a clinician, I would recommend strongly that when you're looking at imaging, you should go there yourself and check for all these features. And sometimes you'll pick up things which are very, very interesting. And actually, this is what thrills you. That thrill which you get and keeping the pictures. I store all my pictures, all images, all my video, kind of edited videos. I don't like to store unedited videos. Where I feel a video is good, I'll just store that. I don't store every video. So every image also I don't store. See, another picture which I have stored is a kind of a macular hole developing, like lamellar, but probably going through right. This kind of a patient where it's scary, it might go into a detachment, because the pathogenesis is initially it might be outer lamellar or inner lamellar hole, the full thickness hole, finally a detachment. So another patient which is developing a very kind of a defect in the center, and you see there's a lamellar hole. So probably you can watch this patient, but here it's really reaching the the bottom. So the entire hole will then liquefied vitreous is going to seep through and get a detachment. So this is what I've seen in the natural course, my own experience. So this is one of the patients which, of course, you got a detachment. This kind of a, you'll see the irregular hole. It's not a classical round hole. It's a kind of a defect. I won't say it's a macular hole. It's kind of a defect in these pathological myopes, which you get with MTM. It's actually an MTM. So you see the MTM is there. When the retina kind of retracts back, the MTM is there, but it doesn't appear so obvious. So this is a short clip. I'm ending my surgery talk because I know Anirudh's got other speakers also. So just to tell you that this kind of a pathological map, you have to be very careful. I use the IOCT, integrated OCT, because I want to identify the hole. I also want to make sure my flaps come onto the hole. I also want to make sure I don't get any iatrogenic break. Most important, I want to make sure the flaps are over the hole, because in these detachments, MTM detachments, the main thing is closure of the hole or the closure of the defect. It's not a very regular hole, so it's very important to put a flap there. You're not going to do any laser there. It's definite, because you're not good. Nobody does lasers in macular holes, but if you get an iatrogenic break, you're in a tough situation, because you got a kind of a sclera shining through. There's not going to be no laser take. So this is a totally different ball game, and you have to be very careful. This is a hyaloid which is tightly adherent. Just talking about, and just to tell you in 2 seconds what exactly I mean. I put Brilliant Blue G thanks to we have it available because of the Aurolab people, and I use the Aurolab. It's it works quite well. I have to double kind of put it twice, but it's okay. I use their Octane also, so it saves on the costs, but you get the work done very well, and it's an interoperative solution. And just to show you what I exactly I did, there's a little bit of BBG which has gone subretinal. It's a non-toxic dye, but when I do a paramacular retinotomy to drain the SRFCs, this is what I meant. So here I will show you exactly. I had seen the IOCT, and now I'll show you the IOCT again. So you've got to make sure you just get the blue colored flaps, because these thin myopes, thin macula is actually difficult to peel. You don't identify the ILM so well, but somehow your results may not be so encouraging. Times I've had situations say here the IOCT actually tells you this. It's a very kind of a satisfaction you get on the table. So I take these images and store it. Thank you so much.
Thank you very much, sir. Any questions for sir?
Yes, I'll gladly like to answer if there's anything.
Thank you, sir.
Thank you, sir.
So we'll go to Dr. Raja, sir, who will be speaking on when not to touch subretinal fluid.
Good morning, everyone. Thank you to Anirudh for including me in this instruction course. I'll be talking about when not to treat subretinal fluid. It's a trick question, like exam student is there, PG, and examiner will throw questions and things like this. And you have to come up with innovative, various answers. The examiner will keep asking what else, what else, what you have to keep on thinking, because it's not related to a particular topic. I think it's not related to ARMD when you don't want to treat. It's a very broad thing which I have put in here. So overall, there are some conditions where we know that it's a well known teaching that in very acute CSR, usually we give time. So you don't have to rush someone who has 5 days history of acute CSR unless there are some specific indications. We know there are some exceptions. We are not going into that, but that is one condition where you actually have subretinal fluid, but you can observe. And I will also be showing later on some conditions where you think it is subretinal fluid, but it's not actually subretinal fluid. But there are conditions like here, there is subretinal fluid, but you can wait for some time in these cases. What about macular degeneration In macular degeneration, now there is a concept that you look at different compartments of fluid, intraretinal fluid or subretinal fluid or even sub-RPE fluid. So, generally sub-RPE fluid in general we have not been treating, but intraretinal fluid is definitely harmful, subretinal fluid is less harmful, and the fluid study has shown, but we have to take it in the right way. It doesn't say that don't treat subretinal fluid. It says that you can treat and extend. But what in treat and extend means is you are actually injecting every visit. Whether there is SRF or no SRF, there is no option of not treating a patient. You still inject him, but you are injecting as if there is no fluid. But you don't have to like be aggressive if there is only subretinal fluid and it's less than 200 microns. I'll just show the even in the CAT trial and VIEW trial post hoc analysis, it showed that those who have intraretinal fluid, the vision loss is much more. Those who have subretinal fluid, the vision loss is less. In fact, those who did not have SRF probably had slightly less vision compared to those who had SRF. So, less than 200 microns you can tolerate, but you are injecting. You are not basically coming back to monthly injections. You can still extend. Another condition where you are not going to be very aggressive or probably you are going to give time is in the immediate postoperative period. For retinal detachment, we know that OCT studies have been done that you do the first day, 1 week, sometimes 1 month, sometimes 6 months. Under the macula, you can still have fluid, so you don't have to rush in immediately within a few days to go back to the operating room to redo the surgery. Another condition, mactal, there can be non-neovascular exudation also. They just subretinal fluid kind of pocket. You don't have to treat those conditions. What about dome-shaped maculopathy? There can be SRF. People have tried different ways, X, Y, Z, and overall, it may or may not make much of a difference. But be careful if there is any CNVM in these cases. Then you have other diseases, dystrophies. Sometimes you can have best or even adult vitelliform. Sometimes focal choroidal excavation is there, which is non-conforming, and you think that it's SRF due to some pathology. You don't have to treat those conditions. So that was best. Then even adult vitelliform you can have. The other thing which I wanted to convey is what kind of treatment. We are sometimes very keen or eager to give injections in the eye, and that is something we should be very mindful about. Even if there is subretinal, some dark space on the OCT, you want to give injection, but be careful about at least the diagnosis, whether the it is indicated or not. We have seen many patients of acute CSR also being given intravitreal injections, knowing that it is CSR, knowing that it is SRF. But sometimes there is the other way around also. Sometimes it can be confusing whether there is CNVM or not. This was a patient with acute CSR. Fibrin actually was misdiagnosed as CNVM, got injections. We did an FA and Navilas laser, and this fluid went away. This is another case where, sorry, I'll go back. Where a patient had history of trauma, small macular hole. When you are seeing macular holes, in this case we did not do any surgery, but even after surgery of our macular hole, you can have some amount of fluid. It's a course of remodeling over a few months or weeks that the macular hole, when it closes, there will be a pocket of SRF, so you don't have to worry about that. Sometimes very basic, there is actually no SRF in some conditions, but we may get carried away or mistakenly say that think about SRF. So people have long photoreceptor outer segment tips, and that sometimes if you look carefully, if you have a very nice OCT, you may mistake it for subretinal fluid. It's not subretinal fluid. The other condition which may make it mimic subretinal fluid, masquerade. So there can be many, but if you have any photic injury, welders, laser, solar retinopathy, you can have a loss of the outer segments and it can look like a subretinal fluid. But in a subretinal fluid, there is a surface tension, so it will have a slightly higher center, and on the sides there will be an angle. Whereas in these photic injury, solar retinopathy, it will be a straight box-like lesion. So you can make out whether it's subretinal fluid or not. The other mimicker is outer retinal tubulation. Many of you may have heard about it. Uh, this is due to photoreceptor regeneration. There is an inner lining to these, and these are not typical subretinal fluid. You need to be careful. The other condition, sometimes we do not examine clinically. Patient shows one scan, and we say you have to give an injection, but always go back and see what the cause of this fluid is. So uh, this is a case who was sent, who was shown advised injection and came for opinion. What do you think? And I saw there is nothing special that I am able to see for the cause of this fluid. But when I examined carefully, did another OCD, it's actually a macular hole. So overall, these are, as Anirudh was saying, the beginning of my presentation is like an exam, like, what else, what, maybe there will be many else, you may be able to add something, but these are some things which I could think of. And with that, I would like to thank you all for your kind attention.
Thank you, sir. Any questions for sir? Sir, I have a question. So we have some patients of chronic CSE where let's say you have a chronic sub, and let's say if you don't have an OCT angiography, when do you decide when do you decide that there is possibly an underlying CSE and an anti-VEGF can work? Because sometimes even if you have OCT angiography, the membrane may not show clearly, or you may not be sure that there is a membrane. So how do you decide in those cases?
Yeah, very good question. I don't know if one of you has a presentation on pachychoroid, but when you see on the OCT, what Dr. Anirudh is asking, OCT you may not have. Even if you have, it can bowl a googly at you many times. In the sense, you don't understand what it's showing. Is there a CNVM or not? But if you see a RP irregularity, flat irregular PED, then that's a high suspicion for a CNVM. If you don't see that, and an OCT is showing something like a flow signal, you're probably going to take that as a CN with a pinch of salt, probably, or more than that. But a flat irregular PED on a traditional OCT B scan is a very important finding when you should suspect CNV in those cases. And there is fluid. For me, ICG is a must for pachychoroid diseases, but you should definitely suspect CNV in those cases.
Thank you, sir. So with this, we can go to our next talk. Dr. Vishali ma'am is here. She'll be speaking on multicolor imaging.
Thank you very much, Anirudh, for giving me this opportunity. The topic which was allotted to me was multicolor imaging, and why is it important to us? Okay. We all understand that now with most of our instruments like that we are having spectralis and everything. Okay, that's fine. Most of our new imaging cameras, they don't have true color. So they have multicolor, and we have publications in Retina, ERMs, AMD, so on, which indicate that multicolor is better than true color. Now, does it apply to uveitis as well? Because our requirements are very different. So when there is a posterior segment inflammation, many times you would see, even in the meetings when we show you choroiditis, pigeoness-like choroiditis and all, this is the backbone of posterior uveitis, because we are taught that if you see yellow, it's active, if you see dark, it's inactive, and if you see a membrane, you will see certain colors. However, there are no studies available whether we can apply multicolor CSLO confidently in these kind of situations where we have active inflammation or even the healed inflammation in the posterior segment. So the purpose of this study was to compare multicolor scanning laser with the standard digital color photograph in posterior uveitis. It was done as a thesis of Kajri, who's here in Anirudh, and Kanika, and lot of people were involved in it. So what we did, we had 69 eyes of the patients who came to us in different stages of posterior uveitis, both active and inactive. So all underwent imaging on multicolor as well as the standard. The multicolor was Spectralis and standard was our old Visupac Zeiss camera, the conventional one. So after acquiring the patient images, a clinician who was blinded to the imaging data kind of evaluated whether it was active, inactive, and they gave their comment. And then there were three of us, me, Anirudh, and his lovely wife Kanika, and Kajri showed us all these blinded images, and we believe we have a lot of experience in uveitis. So we marked it. Is there a active? Yes or no. Is there retinitis? Yes or no. And then we went back to other imaging like OCT, ICG, and confirmed that what we were suspecting on color imaging, was it true or not. So it was very interesting results. So when we looked at the epiretinal membrane and inner retinal stria, they were actually better defined on multicolor imaging compared to the standard color photo because of the different wavelengths that it offers, blue, green, and all. So for epiretinal membrane it's good, and maybe that is what has been published for retinal pathologies, one of the things. Multicolor imaging could detect ERM in 5 eyes when it was not present. So it is sometimes over-diagnosing. So if you happen to see ERM just on the photograph on multicolor, it's always good to confirm it on OCT because sometimes it may not be there. And then we come to the depth of the lesion. As you understand, in uveitis, it is very important to know whether it is retinitis or is it choroiditis and what is the depth of the lesion. Now here is where we all got caught. So the results were very poorly defined on MCI, and we found that if you are looking for the disease activity, active choroiditis was very difficult to diagnose on MCI compared to the color fundus imaging. So I will show you the example of the cases. Like we were shown this image, multicolored image. What was it? Like none of us actually said this was a case of retinitis because we were wondering, is there a choroiditis here, and then there is this color, and then there is hemorrhage. And when you compare it with the standard color photo, you see these yellowish lesion because that is how we are taught that active retinitis has to appear yellow. When it doesn't appear yellow, we are not able to relate to it as active retinitis. So looking at this, we missed retinitis. Looking at this, we said, oh, this is retinitis, looks viral, because once you look at it, you know what you mean. Problem was not only in the identification of the depth, but it was also whether the disease is active or not. And very interestingly, we had 46 eyes that had active choroiditis, and on color only in 37 we said there was, and almost 100% on the standard color picture, but on MCI it was 80%. For inactive choroiditis, MCI was very good. The problem was with activity. So let's see this lesion. This is what it is. This is the MCI. We could not pick up this choroidal granuloma, to be very honest with you, with all our experience. So if you see this circle here, we thought it was fine. There was nothing. But if you see the standard color picture, there is a granuloma sitting there, which you can't miss. And these are the individual color channels, infrared, green, and the blue reflectance, none of which actually showed that there could be a granuloma. Similarly, this is the MCI, or the multicolor imaging of serpiginous-like choroiditis. If you see here, it all seems healed. The healed lesion is appearing very good. And these active arrows indicate none of us said this was active. We all thought it was healed. unless we went to the color picture and we realized, oh, the edge was so active. So I think my time is up, and the vasculitis again was a problem. We could detect only in 50% of the cases. Occlusion, fine, you can see occluded vessel, but the active vasculitis is a problem. And then there were confusion like here. We thought it could be a hemorrhage, which it was not, but that is probably we were not used to of it. Like this is a pigment sitting here, and when we color, we thought maybe there was a hemorrhage or a membrane. Now we are getting smarter because we are getting used to of the revised color scheme, but in the beginning, this area of pigment here appears red on multicolor imaging. So to conclude, these days we are relying a lot on color pictures, and many a time you, even in WhatsApp group, you see somebody posting a color picture. What is the diagnosis? So if you are posting a color picture of only MCI and not the true color picture, your experts may give you a very different advice, and that could be a source of problems. So don't rely on this image alone. Rely on your clinical judgment. Thank you very much.
Thank you, ma'am. I think that was a very important point, and I remember we had a patient of toxoplasmosis retinitis, and the multicolor photograph was circulated in our groups in Abu Dhabi, and nobody could actually pick up the retinitis looking at the WhatsApp image. So, any questions?
In there of teleconsults and all, I think it's very important too. Because all of us follow Retina like mad, and if Retina people are saying it's very good, but for us it doesn't work in UVA.
Good presentation, Doctor. One question on subretinal. You showed where looked like a false positive subretinal hemorrhage when the but what about the reverse when there is actually subretinal hemorrhage, faint hemorrhage on
We
CST?
could not detect that also.
Yeah, because everything looks red, you know, color.
We had, because we were shown just images and nothing else. And on images, our diagnoses were very, very different. And the moment you see the true one, you say, oh, you know, this is what it is. So maybe Anirudh is going to work on it to create a kind of uveitis consensus on color photo images, MCI, and to define what should be the definition of retinitis. Maybe we have to change it from the classic yellow appearance to green appearance, or I don't know, you know. Yeah. I think when you are looking at the vitreoretinal interface, the epiretinal membranes, and some of the mactel is seen very well. Some of the things are seen very well. But for inflammation and depth, it did not work. Maybe we relied too much on the color. Maybe in UVR, that's the thing. Thank you.
Thank you. So we can now move on to Dr. Darius Shroff, who will talk to us about membrane peeling and how to avoid surprises.
Good morning, everyone. Thank you, Anirudh, for having me as part of this. This is actually based on a publication which we jointly did with Anirudh and PGI, where we got a little bit of a shock, so that's why I thought we'd present it. So why this talk? Remember the Hippocrates oath, first do no harm. So let's see how we do no harm to our patients. What could be the cause of surprise after membrane peeling? Most commonly phototoxicity, dye toxicity, or the surgical technique itself. Coming first to phototoxicity, please remember that blue light has the highest phototoxic potential. And this is not a new phenomena. Even if you see this article, which was published in AGO in 1992 from Gary Abrams, you can see this sort of phototoxicity and RP changes reported by them. And these have been seen even later, and even it's said that even with maximal precautions, macular phototoxic damage remain a factual danger for all of us. So there was some international commission for non-ionizing radiation protection. So in fact, those guidelines were quite drastic. The working distance, of course, matters. So you can see from this slide, if you increase the working distance from 4 millimeters to 8 millimeters, the safety increases, and the surgical time, the safe surgical time, even triples in many of these cases. So the distance from the retina which you are holding the light really matters. Dye toxicity, So of course earlier we had a lot of reports on the toxicity of ICG. So we have from IOVS, graphase, etc. The reports of the toxic effect of ICG. And then trypan blue was the new kid at that time on the block, and they found that it does not cause significant toxicity compared to ICG. So this was the classic kind of appearance of ICG toxicity post macular hole surgery with RP changes. And then we all thought we were very safe because we started using BBG and everybody said BBG is absolutely safe, nothing happens with BBG. And we saw two cases at in Delhi and one case from Dr. Anirudh at PGI. We were shocked, and in fact this was published in our retinal case and brief reports. So these are just briefly about these cases. First case was a patient with VMT and ERM. ILM blue 0.025% was used, and this was the xenon light at 60% was used. During the surgery, a microscope integrated OCT was used. I'll just quickly show you the video, although the video is not nothing very exceptional. It's just to show you that sometimes if you're using these new toys like OCT guided, you get so enamored by that, you keep looking at the OCT, your surgical time basically becomes much more, because when you're using a new tool like this. And this standard ILM peel, and we avoided we did a fovea sparing peel for this. So that was scary. The second case was a case who had a RD, a macular hole RD, again underwent ILM peeling, and you can see how horrific the picture looks with the RP changes post-op. And the third case was a one who underwent ERM removal, and again we see these changes. What is very interesting is you can see that these patients all had this extending nasally, but we did not peel nasally. You see, the peeling would be at the posterior pole, but they had this RP changes going nasally. So everybody is wondering why this was happening. And also it's important to rule out photosensitizing drugs, allopurinol, furosemide, etc., which could cause this, but none of our patients were on this. There was a similar report from Narayan Netralaya, where combined brilliant blue G and xenon light created, and you see the picture is quite similar to our cases also here. So basically it was felt that it is a light and dye interaction which causes it. A wavelength more than 400 causes the phototoxic effect, and xenon has a peak wavelength of 450 nanometers. And the increased absorption of the xenon light by BBG and changes in the emission spectrum of BBG causes toxic free radicals and damage to RP cells and photoreceptors. And the RP cell viability is reduced in the presence of BBG, especially when you use focal high illumination. So the combination seemed to be lethal and induce photosensitivity of tissue causing this. So what we just need to be mindful about this, because this is a very, very rare occurrence, reduce the exposure time, especially avoid restaining as much as possible, keep the light source away from retina, and of course some factors are beyond our control. Thank you so much.
Thank you so much. Any questions for Dr. Shah?
I think so. One thing we make sure now is that the time of the dye staining, we ask the nurse scrub sister to look at the, because we have a clock with seconds, and we make sure at exactly 30 seconds. So at 25 seconds, she says, sir, 25 seconds. So then we put on the, because we clamp the infusion and inject the dye. So then we open the thing, put the flute in or cutter and suck it out. So we're mindful of that. We don't leave it to kind of stain for a long time. And the second thing is light also, light pipe little away. We keep telling our fellows, of course, even the videos come very horrible when the light pipe is very close because of glare. But the second thing is this toxicity issue. So we have to be mindful of these two. I think Dr. Raja, Dr. Atul, Dr. Vishali would.
No, so we have also seen, cases like very horrific post-operative results, and it is a combination. It's not just changing the dye even if you leave for 1 minute. It's not just the light. I have done experiments on ARP19, ICG, trypan blue, and published them. It's the combination of light, and if you are doing for a long time, whether it's a new toy or a fellow, and especially with the older light sources where you keep at 80 or 100, so one of the videos where it was 100%, that if you are holding near the macula, you don't realize, you see a very nice illumination, you continue doing the surgery. Half an hour you have held the light near that, it's going to cause toxicity. And you said it's not why it was nasal.
Yeah.
If it's on the left eye, that was the left eye. Your left hand is like this, your angle is like this. Okay, but if you do on the right eye, it will be more temporal to the macula also. That toxicity
Because
which we'll see.
Anirudh is laughing, sir, because the reviewers of the RCBI wrote this, the retinal crisis. They said, why was it nasal? Because this will not explain the.
Yeah, it's
that
not
the,
related to
the reviewers wrote
feeling
this.
size or area or anything. You
Yeah.
won't feel that. And it's not as if the dye is going more nasal. It's the light which is at that angle in the left eye. On the right eye, it will go more macula. But it's the light duration which you should be very mindful of.
Thank you, sir. Thank you. So we can move on to Dr. Jayesh Sheth, who will be talking to us about pachychoroid.
Hi, good morning everyone. So first of all, thank you Anirudh for inviting me to be a part of this IC. And my talk will primarily be focusing on two cases where I feel I've had more misses than hits, and I guess I'll need active inputs from all the experts over here. So we'll straight away go to the first case. This was a 45-year-old lady who presented with decreased vision in the left eye of 1 month duration. Her visual acuity in the left eye was 6 by 36 N18 and 66 N6 in the right eye. Fundus examination of both the eyes showed presence of lot of tessellations with presence of serious macular detachment in the macular area in the left eye. Now the right eye multimodal imaging including the OCT, fluorescein angiography and the ICG was absolutely fine. Now we'll proceed to the left eye. Left eye showed presence of the serous macular detachment with presence of few underlying pachy vessels, and as Dr. Raja sir had pointed out, there was presence of a flat irregular PED which was quite shallow in nature. On doing an angiographic imaging, the fluorescein angiography showed presence of window defects in the early and the late phases, whereas when we see the ICG angiography, there was more of mid-phase choroidal hyperfluorescence with absence of any network or polyps that were at this stage. So I came to a working diagnosis of CSCR and started the patient on oral eplerenone and topical neparfinac drops. Over the next 2 months, there was a good reduction in the subretinal fluid with an improvement in the visual acuity up to 6 by 18. Now, unfortunately, the patient came 3 months later with a worsening of the subretinal fluid and the visual acuity dropping to 6 by 60. Now, at this stage, the flat irregular PED had actually increased. So, I repeated an angiography again at this stage. The ICG showed a very similar picture. There was a very suspicious network at this stage, but which was not very much visible on ICG. And so, at this stage, I did an OCTA. So there was a faint network that was visible at the posterior pole, and hence I came to a diagnosis of a pachychoroid neovasculopathy at this stage. And this is a multimodal imaging showing at this stage. So this is the zoomed in image of the ICG. A very faint network is visible, and this is the corresponding OCT of the patient. So for this patient, I did a full fluence photodynamic therapy along with intravitreal ranibizumab, and 1 month later there was a complete resolution of the fluid on OCT, and the network had completely resolved on the OCT angio. However, again after 3 months the patient's visual acuity was stable, but OCT angio showed a recurrence of the network, but there was absence of any OCT biomarker of disease activity. So I have been observing the patient, and even at 1.5 years the patient's visual acuity gradually improved up to 6 by 18. The network is increasing in size, but still absence of any OCT biomarker of any disease activity. So just few points of discussion. There was CNVM missed at baseline, and there was an improvement on conservative management. So was it just a CSR at baseline which then converted to a neovasculopathy? And should OCTA be done for all suspected networks? And if we do not have access to OCTA, what are the OCT biomarkers that may give us a hint into an early identification of an early network? And if there's a quiescent network, what should be the way forward? So I think Anirudh, should I go ahead with the second case or should we just discuss? Okay. So this is a second case. This is a 64-year-old male who came with reduction of vision in the right eye since 1 week. His visual acuity was 6 by 45 and 36 in the right eye and 66 and 6 in the left eye. Now the right eye showed presence of a large pigment epithelial detachment in foveal region and another in the peripapillary area. And in the left eye, there was presence of pigmentary changes just inferior to the fovea and track marks that were seen temporally. Now, if we see the OCT of the right eye, there was a presence of an extra large pigment epithelial detachment, and the Brooks membrane was not visible. I think that is most probably because of the large size of the PED rather than considering a hemorrhagic PED kind of feature. And there was an area of RP thinning that was there superior-temporal to the area of the fovea, and this is the another peripapillary PED that was there. If you look at the other eye, the foveal section was normal, but there was kind of an RP aperture inferior to the foveal area with presence of an intraretinal fluid. Now this is the autofluorescence of the patient. And there was a hypoautofluorescence at the posterior pole in the right eye that corresponded to the area of the PED, and another dense hypoautofluorescence that was present that probably corresponded to the area of the RP thinning. And in the left eye, the track marks are visible on the autofluorescence image along with a dense hypo corresponding to the area of absence of the RPE. Now this is the angiographic image of the right eye. Now on fluorescein angiography, there was pooling of the dye that corresponded to the areas of the pigment epithelial detachment, and a staining was seen corresponding to the area of the RPE thinning in the right eye. The ICG showed hypocyanescence corresponding to the large area of PED and the area of hypercyanescence that corresponded to the area of the RPE thinning. Now this is the multimodal imaging of the left eye. And on fluorescein angiography, again there was staining present in corresponding to the area of the RP loss, and along with that track marks were visible temporally, and the ICG did not show much significant changes. So was it just an occult CNVM or was it just an extra large PED? So I went ahead and gave one dose of injection of ranibizumab since the patient was very symptomatic. Now unfortunately, after a month the patient had significant worsening of the vision, and vision acuity dropped to counting fingers 3 meters. If we look at the corresponding IR image, the PED size had massively increased and covering the entire pole to pole, and there was presence of IRF and SRF at this stage. So in view of the drop in the visual acuity with a massive increase in size of the PED, I switched the patient to aflibercept. Now thankfully the patient responded very well to aflibercept, and after a month his visual acuity improved to 6/18 N10. There was almost near total collapse of the PED and dissolution of the intraretinal fluid with presence of an early focal choroidal excavation at the posterior pole. And when I went through the scans, as I think Atul sir correctly pointed out, it's very important for us to actually go and visit the imaging room and look at all these sections and not just sections what our technician may upload. So there was presence of an RP rip that corresponded to the area of the RP thinning that was there pre-injection stage. Now the patient received 2 more doses of aflibercept, and at the end of 3 months his visual acuity improved to 6/9 parts with almost complete absence of fluid at the posterior pole, and there was very mild SRF that was present temporarily, and I was just observed the patient at this stage. Corresponding to the area where there was RP loss, there was a proliferation had happened and the RP defect was covered. So for this patient, the few points for discussion was the treatment actually needed at baseline, which regimen and molecule is ideal for this patient, and should we continue injecting even after we develop an RP rip? Thank you.
Thank you, Jay. Any
I think most probably it could be a CSR with a PED. I couldn't see any network. Unfortunately, I have not done a imaging after the PED had collapsed completely. Or there could be an underlying occultation. That would be my second differential.
any comments? Sir?
Okay.
There are, I mean, this can have a discussion of half an hour also. It would have been good if the way of presentation is show one image and ask the panelists and audience what now. Because once you have some features later on, then you can guess now what would have been there time. But these are always challenging, that if you have such large PEDs, you are not sure whether or not.
True.
You don't treat, the patient comes back, say the doctor made a wrong diagnosis. But if you treat and still the patient develops hemorrhage, because it's not absolute necessary that with treatment everything will be like this. Actually the rip is the reason why suddenly if you have
Suddenly there was a
really
collapse.
it flattens like this, it's very with brolucizumab maybe we are seeing some cases, but otherwise you must suspect a rib which has reduced the tension and
The flattened.
either way it's always a second. These cases are extremely challenging with such PEDs. I would not say at this time that you should have injection early itself and it would have saved something, but fortunately for this patient did not affect the central macula, and as Dr. Atul pointed out, yeah, if the pathology is still there, you still need to treat.
So would you treat at baseline, and what would be the molecule that you would have preferred at presentation for the patient?
Yeah, in this patient, since the patient was symptomatic, time I prefer brolucizumab in these cases. Although I don't have too much experience, the bleeding can still happen even with that. Looking to treat the P, yes, it's a better molecule. It has a better penetration.
True. Any other comments or questions?
Hello, hello,
Yeah. Thank you.
hello, 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 hello,
Thank you,
hello,
Jay. I
hello.
think I'll just take 2 minutes for my talk. We are already, I think, time up. So I think we had great cases and great discussion. Um, I'll be just talking about quantification of choriocapillaries, and
Hello,
it's not
hello.
really a talk, but it's like an invitation to all of you who are interested in imaging. And we are now starting to do a lot of quantification of choriocapillaries in Abu Dhabi. So I'd like to start off with this systematic review that we have recently published in Ocular Immunology. We've moved on from two-dimensional imaging to volumetric analysis. And so issues such as CVI measurements are really, they have their own limitations because of the artifacts. And recently there are a few studies that have been published, and increasingly many of the labs, they're doing these studies. So they're using free softwares such as you have MATLAB and other complicated softwares, but we can always use ImageJ, Fiji, which are freely available to measure a lot of indices. So we are now doing vessel densities and flow deficit area analysis, and a lot of these aspects we can easily do without spending any money on this, using third-party software and simple thresholding techniques. So this is just a short video to show you how easily this can be done. So you basically just export the image to Fiji, and we run a macros. So we can just create a macros. It just takes couple of seconds to then go ahead, use the macros, and obtain the flow deficit area quantitative analysis. So we can actually do it on a number of pathologies in uveitis and in medical retina and obtain measurements. Of course, we have to be mindful of obtaining the correct scan. So it doesn't matter, you don't have to do anything special, you just take a routine OCT angiography, but the importance is when you're exporting the image, it has to be at a proper depth and it has to be at a proper location. So whenever you have the image, the depth of the scan is vital, and when we are exporting images from the machine during analysis, we can always tell you how to do it. Again, you can use various thresholding algorithms. So each thresholding algorithm will give you a different set of results. So we have Fansalkar's threshold which we use, and that's now standardized for choriocapillaries analysis. So basically you just binarize the images, and once your image is binarized, you take out the superficial plexus, and then you kind of obtain a map of the flow deficit area, and this gives you the analysis. So you can do it at baseline and follow up and see if there is any increase, for example over here, of the flow deficit area. So this can be all automated, everything can be quantified without resorting to any complicated or expensive imaging algorithms. And with that, we'll end our session. If there are any questions, we can take up, or we can move on to the next IC. Thank you, sir. Thank you for being a part. Thank you. Thank you, everyone. We can have the next session.